Assalamu alaikum wa rahmatullahi wa barakatuh. We'll start tonight our short webinar about one of the most important diseases that affect the pediatric age during this time of the year with the start of winter. Our talk today will be about status asthmaticus in pediatric and its management. Our speaker will be Dr. Fawaz Al-Anazi. Dr. Fawaz is Assistant Professor, College of Medicine, Al Faisal University, Consultant, Pediatric Critical Care Department of Pediatrics, King Faisal Specialist Hospital and Research Center in Riyadh. We are welcoming you, Dr. Fawaz, in Saudi German Hospital, Riyadh, hoping you and all our audience good luck and a fruitful presentation, inshallah. Okay, Dr. Fawaz, you can start.
Thanks, Dr. Nabil, for the invitation. I'm happy to talk today about the pediatric asthmaticus. As you know, the intensivists will always love to talk about the physiology and the pathophysiology of the diseases. So our agenda for the presentation today, we're going to talk briefly about some of the history of the asthma, and then epidemiological data in US and in Saudi Arabia. Then we'll talk about the pathophysiology, which we're going to spend a little time around that, the pathophysiology, and then we'll go through the clinical presentation, history, physical examination, investigation, and quickly we'll review the PICU management. Asthma was first used in clinical context by Hippocrates and describing respiratory findings such as dyspnea, tachypnea, and orthopnea. It was later, 500 years, recognized by Aratus, as he suggested that the cause of asthma was coldness and humidity of a pneuma, and will be result in thick humor. Today, with the discussion does not include pneuma. Rather, asthma was defined as a chronic inflammatory disorder causing recurrent episode of wheezing, shortness of breath, chest tightness, and coughing associated with airflow obstruction that's often reversible. Status asthmaticus is also known as acute asthma, acute severe asthma, or acute asthma exacerbation. Acute severe asthma exacerbation, which is progressively worsening bronchospasm and respiratory dysfunction due to an asthma which is unresponsive to standard conventional therapy and may progress to respiratory failure and the need of mechanical ventilation. The epidemiology in US, it affects almost 25 million people, including 6 million children under age of 18. It's significant. It has significant impact on health and economic burden, in addition to the family and to the patients themselves and their family, and also society. In 2016, 1.8 million people visited the emergency for asthma-related care, and in the same year, 189,000 people were hospitalized because of asthma. This diagram showed asthma prevalence over since 1980 to 2017. As you can see, it's affecting both adult and pediatric, and you can see the prevalence went up in the from 7.3 to 7.9 in 2017. This is the current prevalence in the last 17 years. As you can see, there is also increase in number, which showed in the orange bars. There's another diagram showed asthma attack prevalence among children and adults with the current asthma. You can see it's slightly reducing over the between the from 2001 to 2017, but the mortality is still there. asthma deaths as well in United States. All these data is presented from the National Center for Environmental Health through the CDC website. The asthma death from 2001 to 2017, it's reducing from 14% to almost 11%. However, if you notice that in the last few years during that period, from 2012 to 2017, the asthma deaths rate is still the same. Saudi Arabia is not far away from these data. According to the study, meta-analysis study, they documented that it's one of the most common chronic diseases in children with increasing prevalence. It has also an impact on children and their families and the community, which cause in terms of loss of work, school days, poor quality of life, frequent emergency department visits, in addition to hospitalization and deaths. They found that inadequate knowledge and unfamiliarity with the new drugs and lack of awareness of the importance of the disease control are common among primary care physicians who care for asthma and care of asthma patients in our country. In addition to these factors, there are others actually attributed to the burden of the disease, such as socioeconomic status, number of siblings, knowledge of the caregiver, and also the income. According to the meta-analysis that I mentioned earlier, the prevalence of asthma in different regions of Saudi Arabia, it was recorded, and it showed rise in asthma prevalence from 1990 to 2000, with stabilization and prevalence of the asthma since 2000. The overall prevalence in Saudi Arabia ranging from 8 to 25, based on the studies conducted over the last 3 decades. The increasing of prevalence of asthma may be attributed to the life changes related to the modernization of Saudi society, and change in dietary habits, and also exposure to the environmental factors such indoor allergens, dust and sandstorm, in addition to tobacco. In addition also to the increased asthma awareness in general population and also among the healthcare providers, allowing them to pick up more cases of asthma. This is a publication talking about, it was done by Christopher, was published in the Journal of Pediatrics, and it was talking about the fetal and near-fetal asthma in children from a critical point care perspective. They recruited patients from 8 different tertiary PICU centers. All of them were ventilated. They found the mortality rate was 4%, and most of the deaths were associated with the cardiac arrest prior to the PICU admission. Most of the asthma-related deaths in children occur as a result of respiratory failure or cardiopulmonary arrest that occur before the obtaining the medical care. They also mentioned the clinical risk factors, which include the most of you might be aware of these factors: past history of ICU admission, respiratory failure, or rapid, sudden, and severe deterioration. Psychosocial and ethnic risk factors include poor compliance with outpatient medical treatment, failure to perceive the severity of asthma attack, inner city residence, denial of disease severity, in addition to non-white race. We're gonna move on to the pathophysiology, or we're gonna start with the genetics of the asthma. And actually, there is no single asthma gene has been identified. It's likely that the disease is both polygenic and environmental related. more than 20 chromosomal region has been linked to the asthma. The most consistently linked region have been reported on the chromosome 2, 5, 6, and 12, and 13. In addition to that, it's known that the asthma inheritance is likely related to the inheritance of the atopy. That's why it's very important for us to ask about the history, and we're going to come to that later on in the presentation. Studies in the twin with asthma reveal significant genetic similarity, but no identical phenotypic manifestation of asthma. The immune dysfunction and inflammatory response that occur in asthma, it's highly complex, and it's intermittent and reversible lower airway obstruction due to smooth muscle constriction and airway narrowing. In response to the environmental trigger, often is in association with the viral airway infection. Numerous inflammatory pathways to the airway swelling result in many clinical phenotypes of pediatric asthma. This is just the small diagram showed the normal airway, how it looks like. And on the right side, it shows the airway, how it looks like during the asthma exacerbation. You can appreciate narrowing in the airways, with which cause limited airway airflow, and also tightening of the muscle constrict the airway, in addition to the inflammation and mucus presence in the airways. You can see in the lower bottom of the slide, the thickened airway wall and the normal airway. The pathophysiology of mechanism that underlying these changes are diverse and heterogeneous. They are driven usually by a variety of cell types, include immune cells, mainly T helper cells, mast cells, eosinophils and neutrophils, as well as structural bronchial cells, which include epithelial cells, myofibroblasts, and smooth muscles cells. The presence of these cells it's correlates with the severity of the disease. And in addition to the above mentioned cells, there are also cytokines, chemokines, growth factors, and lipid mediators, and also immunoglobulins, in addition to the histamine. There are two bronchospasms that happening in asthmacs and during the attacks of asthma, and it's important to understand these two process in asthma exacerbation, so you will understand that which one is more sensitive to the bronchodilating agent. So if the patient presents early with early bronchospasm presented to you in the emergency, most of what's going on is degranulation of the mast cells, usually in response to the allergen exposure, and it causes activation of the mast cells and release in histamine and leukotrienes. This early bronchospasm is more sensitive to the bronchodilating agent. In late or delayed bronchospasm, of course, with the evolution of the as the disease progresses from the during the early process, the activated mast cells further activate the T lymphocytes, which produce inflammatory cytokines, including interleukin 4 and 5 and 13, with leukotrienes B4, which attracts more inflammatory response and more of neutrophils and further activation of the pro-inflammatory cascades. In addition to the eosinophil, neutrophil, and activated lymphocytes. This stage of bronchospasm, it's refractory or to the bronchodilation, and it's more sensitive to the anti-inflammatory therapy. The inflammatory, this as you can appreciate from the previous few slides, it's inflammatory rich environment. This will result in overproduction of mucus, injury to the airway epithelium. that expose nerve ending, which augment further airway irritability, hyperresponsiveness, and even worsening mucosal edema. And the final common pathway for the inflammatory cascade is bronchoconstriction and mechanical airway obstruction by the edema and the mucus. What about the autonomic nervous system involvement in asthma exacerbation? It's also contribute to the bronchoconstriction through the parasympathetic activation of M3 receptors by acetylcholine and excitation of non-adrenergic, non-cholinergic pathways mediated by the tachykinase. Similar parasympathetic pathways stimulate mucus production and also cause further airway obstruction. What about the pulmonary mechanics? Actually, the pulmonary mechanical dysfunction occurs as a result of the pathological changes, as we mentioned earlier, related to bronchial smooth muscle contraction, mucosal edema again, and increased mucus production, which cause decrease in airway diameter and increase airflow resistance. During inspiration, the negative pleural pressure causes physiological intrathoracic airway dilatation. However, during expiration, pleural pressure approaches zero, causing physiological intrathoracic airway narrowing. This is a normal respiratory cycle. So it's more of passive expiration. And status asthmaticus, with those narrowing of the narrowing and obstructed airways. These physiological differences in airway diameter resulted in easier airway and air entry during expiration, but actually cause airway obstruction during the expiration, which causing air trapping and with each breath, and also cause hyper inflation in both lungs. This is a diagram that showed the time versus flow in pulmonary mechanics. You can see the during the exhalation, usually it goes, it should go in normal patients, it goes to it should go to zero in normal patient, but in asthmatic patients, it doesn't go to zero, where there is an air trapping. You can see it in the green square. This can be appreciated more if you have a ventilated patients of asthma, and as you can see it in the screen of the ventilator. With higher end expiratory lung volumes, which is coupled with the bronchospasm, leading to increased airway resistance, reduced expiratory flow, expiration becomes more of active, as mentioned, which result in high energy expansion, increased work of breathing. That diaphragmatic flattening from hyperventilation cause also additional mechanical dysfunction for the muscle of expiration, and additional also energy expansion. Both forced expiratory volume and forced vital capacity will be decreased in status asthmaticus. The total lung volumes are increased because of increased functional residual capacity. This is just an X-ray to demonstrate what we were talking about. You can see there is hyperinflation in both lungs, and also flattening, which is highlighted by the yellow lines in both hemithoraces. What about the gas changes in the asthma? It also has some abnormality due to the ventilation perfusion mismatch, including intrapulmonary shunting with atelectasis, and also increased dead space, as there is an airway overdistension, which is resulting from a small airway obstruction due to mucus plugging, edema, and bronchoconstriction. Typically, these gas changes abnormality manifested as hypoxia and hypocarbia. Atelectasis from a small airway obstruction causes areas of decreased ventilation, but adequate also blood flow, that resulting in shunt, and leads to arterial hypoxemia. Dynamic hyperinflation in severe asthma can cause significant cardiopulmonary sequences. So now we're going to talk about this in briefly with cardiopulmonary interaction during the asthma. High lung volumes stretch the pulmonary vasculature and increasing the BVR, which is pulmonary vascular resistance, increasing right ventricular afterload, which compromise the right ventricular function and decrease also the right ventricular output. Fluctuation in pulmonary pressure produce significant effect on the intrathoracic vessels and right atrial venous return. During the large negative intrathoracic pressure, which is observed during inspiration, the left ventricular afterload is increased and the systolic pressure is decreased. Exaggerated variation in systolic pressure associated with intrathoracic pressure variation during the inspiration, which we called as pulsus paradoxus, where you can see it here clearly in the diagram, where there is a differences in the drop in the systolic blood pressure around between 10 to 15 millimeter mercury. This can be observed in the arterial wave, and also it can be observed, as you can see, in the pulse oximetry in the second line. What about the clinical presentation and differential diagnosis? Wheezing is the hallmark of the asthma. As we all know, it's critical to consider the broad differential, though, when you see patients with asthma, prior to working him up and treat him as status asthmaticus. The differential diagnosis is large for wheeze, although there are 4 disparate clinical entities must be identified and distinguished from the status asthmaticus, because their diagnostic, they have the different diagnostic and therapeutic approaches. These include pneumonia, foreign body aspiration, and congestive heart failure. Other diagnostic differential diagnosis can be divided into upper and lower airway disease. These include more likely to be present with chronic or recurrent symptoms, such as you see in upper airway obstruction, which usually presented with stridor. It can also present with wheeze, as you can appreciate it with transmitted sound in the down to the lung fields. The diagnostic consideration also include fixed anatomical lesions like vocal cord paralysis, anatomic web, airway hemangiomas, or dynamic airway obstruction. All these upper airway lesions can cause also transmitted sound, which you might recognize it as wheeze when you listen to the chest. Lower airway diseases that should be considered in addition to the infection: congestive heart failure, as mentioned, and cystic fibrosis and alpha-1 antitrypsin deficiency. We always emphasize on taking good history and examine the patient very well, so you will not miss any information in general. Usually the patient present with a history of respiratory distress, cough, wheeze that has been progressed over the last few days. Allergen exposure or upper respiratory tract infection are often the trigger for the onset, and frequently the family can identify those as inciting event. The presence of fever suggests lower respiratory infection, though asthma and pneumonia can occur together. So the pneumonia can also exacerbate the asthma and make the patient present to you with the asthma exacerbation and even status asthmaticus. In contrast to those, foreign body aspiration will usually present with abrupt onset of clinical symptoms. Assessing the time course of the wheeze episode is very, very important when we talk about differentiating between status asthmaticus and foreign body aspiration. And also based on that, you can determine the urgency of required therapeutic interventions, such as immediate bronchoscopy for the foreign body. It's also important to determine the presence of high-risk factors, as it was mentioned earlier in the epidemiology slide. You need to assess for the high-risk factors, which is including the following: presence of sudden deterioration, past PICU admission, previous respiratory failure with the need of mechanical ventilation, and also food allergy that has been associated with the severity of asthma. Physical examination, we always try to do the rapid 30 seconds cardiopulmonary assessment. Hopefully you are most of you are familiar with this slide, who has done the PULSE course. This is the 30 seconds rapid cardiopulmonary rapid assessments, where you assess the appearance, circulation to the skin, and work breathing. This is what you will do if you have patients who has respiratory emergency. You need to check this triangle according to the American Heart Association. Children with a status asthmaticus are often appear lethargic, diaphoretic, are unable to phonate, and have severe retractions with paradoxical thoraco-abdominal breathing. Poor airway movement found in the chest auscultation, which is an ominous sign for impending respiratory or cardiopulmonary failure. Wheezing, which reflects the turbulent flow in the obstructed or partially obstructed airways, usually equally audible in both hemithorax. Unilateral wheeze you should pay attention to, or have other consideration, as we mentioned earlier, for the foreign body or isolated broncho alveolar malacia. The silenced chest is ominous sign, which may indicate either pneumothorax or complete absence of airway due to severe airway obstruction with the respiratory failure. Usually in the expiratory wheeze alone is found in mild to moderate illness, whereas expiratory plus inspiratory wheeze is present in moderate to severe status asthmaticus. Several clinical asthma score has been used to objectively assess the severity of status asthmaticus. One of them is Becker Pulmonary Index score for asthma. It was modified recently to determine the severity by rating the acuity of 4 clinical characteristics, which include respiratory rate, wheezing, inspiratory-expiratory ratio, and also accessory muscle use. The good thing about this score is the advantage of this score is not required to have PEO measurements. So the Becker score of more than 4 is considered moderate status asthmaticus, and has been used as entry criteria for several inpatient asthma treatment trials. Children with a score of more than 7, those patients should be admitted to the ICU. Worth mentioning that such scores are valuable in clinical studies, but they are not effective in predicting the progression of the clinical illness. So it's very important to do serial measurements that allow you to determine the disease progression and adjust your treatment accordingly. Laboratory evaluation, including which is commonly done in status asthmaticus, the arterial or venous blood gas, CBC with differential and also basic metabolic workup. You typically in early in course of the severe asthma, arterial hypoxemia and hypocarbia are found as a result of VQ mismatch and also hyperventilation, since the patient will be tachypnic. As the air trapping worsening and the tidal volume increases, hypocarbia may be replaced by normal or even elevated PCO2, which is very concerning. Lactic acidosis often present in status asthmaticus and usually reflect the combination of dehydration and also excess lactate production from overuse of pulmonary or respiratory muscles. As mentioned, the normal PCO2, I wanted just to highlight that in tachypnic and hyperventilated patient or child with the status asthmaticus warrants a close clinical observation, and maybe it's a sign of early respiratory muscle fatigue. The presence of leukocytosis and CB and complete blood count may suggest respiratory infection as a source of exacerbation. Or if the patient received the steroid, it might be related to that, or related to the beta 2 agonist therapy. The WBC leukocytosis and also the WBC count in conjunction with the chest X-ray and presence or absence of fever will help you to determine the need of the antibiotic therapy / antiviral therapy. Basic metabolic workup may be useful to assess the degree of dehydration and level of electrolyte disturbances. Hypokalemia and hypokalemia might be a result of intracellular potassium shift from exposure to beta agonist therapy in children with status asthmaticus. Also determining serum magnesium value, it's also an important because the correction of relative hypomagnesemia and status asthmaticus may improve the outcome. The chest X-ray is not required for at the time of hospital admission for all spontaneously breathing patients. However, for children who is presented with the first time wheezing or patient require PICU admission should get an chest X-ray. Chest X-ray might show some relevant clinical findings as infectious infiltrate as a trigger for the status asthmaticus, or pneumothorax as a complication of the disease, cardiomegaly, pulmonary edema, or even unsuspected chest mass, which might take you to another way or direction of management of such patients. A clinician who choose not to obtain chest X-ray at the time of hospital admission, careful and meticulous examination looking specifically for signs and symptoms for occult pneumothorax, congestive heart failure, and foreign body is essential to prevent missing important clinical diagnoses other than asthma. We're going to talk about the emergency management for the patient with asthma. Just to highlight a few facts actually about asthma presentation to the hospital. Most of the patients most of the children with asthma who are seen in the emergency department actually don't require hospital admission. Others with mild to moderate status asthmaticus require inpatient admission and usually treated with the oxygen, inhaled bronchodilators, in addition to corticosteroid. Only small percentage of children require PICU admission. Of those, again, of those children with past PICU admission or history of rapid clinical deterioration, children with severe distress despite initial bronchodilator, or those with the Becker asthma score, as mentioned, equal or more than 7, should be considered for PICU admission. There are also other indicators for patients with severe asthma based on clinical examination: altered mental status, respiratory arrest, or rising, as we mentioned earlier, PaSO2, coupled with the clinical signs of respiratory fatigue. Emergency department management of a child with severe asthma should focus on assessment of respiratory failure, followed by therapeutic intervention, which is including but not limited to obtaining an IV access, providing supplementary oxygen, continuous inhaled beta agonist, and also administration of corticosteroid in form of either IV methylprednisolone or dexamethasone. Recognizing such patients who are severely ill with severe status asthmaticus and provide rapid and aggressive actually care, an emergency department can interrupt a cycle of progression of air trapping and air hunger and also respiratory fatigue, and also prevent those patients from getting intubated and mechanical ventilation. Some of the trials suggested to start IV magnesium and or IV beta agonists in the emergency department to aggressively treat those patients and prevent progression to the need of mechanical ventilation. If you reach the mechanical ventilation of asthmatic patients, it's very difficult actually to control them. Once you have them have asthma patients with who require mechanical ventilation in the ICU, it will be a nightmare for an intensivist. In the ICU, patient should also again have an IV access, continuous cardiorespiratory monitoring, of course, and continuous pulse oximetry monitoring. For spontaneous breathing children in PICU, frequent blood gas monitoring is not actually required. You can manage those patients with by just close clinical observation without having indual arterial or central venous catheter. For children who require mechanical ventilation, of course, you have to get both of those, and also have an Foley's catheter in. Critically ill children with status often dehydrated, as mentioned earlier, as a result of decreased oral intake prior to their admission, and also increased insensible fluid losses from increased minute ventilation. Providing appropriate fluid resuscitation and ongoing maintenance fluid is essential. You should be mindful about overhydration, as there is a risk of pulmonary edema due to microvascular permeability, and also increased left ventricular afterload and alveolar fluid migration, which is associated with overall inflammatory process in asthmatic patients. Most children with status asthmaticus will have some degree of mucus plugging, atelectasis and VQ mismatch, and hypoxemia. In those lung segments, with atelectasis, there will be a compensatory hypoxic pulmonary vasoconstriction. Treatment with inhaled beta agonist may induce generalized pulmonary vasodilatation. As a result of that, it might exacerbate the VQ mismatch and worsening the hypoxemia. So in patients with it could be a hypoxemia, and initially when you treat patients with status asthmaticus and you are seeing the patient clinically improving and their oxygen requirement went up, just keep in mind that it could be just a sign actually of improvement rather than worsening. However, you have to keep in mind that patient with hypoxemia who has worsening respiratory or has worsening clinical picture, it might be related to worsening of the disease in form of pneumothorax or other complication of the or severe mucus plug in major airway. So just be mindful of that. It could represent both ways. Oxygen is a part of the management. So whenever you have a patient with status asthmaticus, all of your patients should be on or kept on oxygen. The overriding of physiological derangement in asthma is airway inflammation, as we mentioned earlier. And the thing that can control the late or delayed bronchospasm is the corticosteroid. So you give initially the bronchodilators. Hopefully, with the next few hours, the patient will turn back, and the steroid kicks in his body. Again, the glucocorticosteroids suppress the cytokines production, and also it can induce the nitric oxide synthase activation, which all are important component inflammatory process involved in the pathophysiology of asthma, as it was explained earlier. As a result of their immunosuppressive activity, corticosteroid impede the recruitment and activation of inflammatory cells, so further decrease the airway mucus production and attenuate the microvascular permeability in status asthmaticus. This is an article which was published in 2003 in a Journal of Pediatrics. They were talking about the steroid, using a steroid in asthmatic patients, and their conclusion was early treatment of acute asthma symptoms with oral corticosteroid in children with pattern of recurrent acute asthma may decrease the severity of asthma and also reduce the likelihood of subsequent relapses. Inhaled corticosteroid of no clinical benefits in the treatment of status asthmaticus, while also some emergency departments data suggest that enteral and parenteral administration of corticosteroids are of equal efficacy. In PICU, most of the patients, they are less likely actually to tolerate oral medication. So therefore, the oral steroid administration is of limited value in these patients. Methylprednisolone, as mentioned, is the most common agent used in PICU and preferred because of its limited mineralocorticoid effect. The usual initial dose is 2 milligram per kg, followed by 0.5 to 1 milligram per kg per dose. You are supposed to give it IV and every 6 hours. Other agents that are sometimes used can be used as dexamethasone and hydrocortisone. Depending upon the agent, systemic steroid should begin to kick in 1 to 3 hours and reach maximum effect in 4 to 8 hours. Be mindful about the side effect of the steroid, which is usually hyperglycemia. These are the usual PICU observed corticosteroid related hyperglycemia, hypertension, and also agitation, which is related to steroid-induced psychosis. Beta agonist as a sympathomimetic agent causes direct bronchodilation for the and also the key component actually of acute and chronic asthma therapy. As mentioned earlier, it can be just used as it's a mainstay of therapy with the steroid, and also it can be used as bridge for ventilation oxygenation until the anti-inflammatory effect of corticosteroid take a place. Bronchial smooth muscle express beta-2 adrenergic receptors, which is activated by binding with a beta agonist agent like albuterol or terbutaline after frequent cascades, which will cause decrease in actin-myosin interaction and cause or resulted in smooth muscle relaxation. These can be delivered by either MDI or small volume nebulizer. Continuous albuterol infusion dose is 0.15 to 0.5 milligram per kg per hour, or 10 to 20 milligram per hour. Again, be mindful about the side effect of those medications, which include tachycardia, palpitation, hypertension, and hyperreactivity or tremor, in addition to the common electrolyte disturbance, which is hypokalemia and hyperglycemia. Other medication that can be used also in asthma, thiophanate. This has limited because of more of selective beta 2 agonist is there in the market. Thiophanate has been the use of thiophanate went down. However, we're gonna just talk about it briefly with the loading dose of 5 to 7 milligram per kg. You have to give it over 20 minutes if you have to give it. And continuous infusion of 0.5 to 0.9 milligram per kg per hour. The thing about the thiophanate is you have to monitor the drug level, and also it has major side effect, which is include the cardiac arrhythmias. Anticholinergic effect is the most common use is ipratropium bromide, which promote bronchodilation or bronchodilation without inhibiting mucociliary clearance, which makes it great according to the pharmacodynamics. Although when it's administered in the emergency, it can reduce the hospital rate or the hospital admission rate and clinical asthma score. However, its effect on moderate asthma in children not proven. If you want to use it, the initial dose is 125 to 500 microgram every 20 minutes. Then you can use it every 4 to 6 hours. Personally, I use it for the first 24 hours. If there is no effect, I won't continue because of those conflicting data. Magnesium sulfate acts mainly as bronchodilator through calcium channel blocker, as it inhibits calcium-mediated smooth muscle contraction, and also by this will facilitate the bronchodilation. Usual dose 25 to 50 milligram per kg per dose. It's given over 30 minutes, then every 4 hours. It can be given as continuous infusion as well, 10 to 20 milligram per kg per hour. Side effect that you have to be careful about is include the hypotension, sinus depression, and muscle weakness, in addition to the flushing. Helium oxygen combination, when it's used 80 to 40, or it's used to 60 to 40. The idea behind it, it's low density gas. It's reduced the airway airflow resistance in the small airway by reducing the turbulence flow and enhancing laminar gas flow. The administration of such combination and status asthmaticus unproven therapy so far. People are moving more toward the use of non-invasive mechanical ventilation. So if you have a patient with worsening status asthmaticus, I would go after the medical therapy just to the non-invasive mechanical ventilation, which is there is more awareness about using it in the in status asthma overall, actually in PICU care. And also in the status asthmaticus patients. It's an alternative to the conventional mechanical ventilation, and being used in the 3 to 5% of critical ill asthmatic patients, based on a study which was published in Pediatrics Critical Care Journal in 2012. The non-invasive positive pressure ventilation in children with lower area obstruction. This is published by Peter. They conclude in continuing medical education article, they conclude that non-invasive ventilation can be effective treatment for children with actually acute lower airway obstruction. Another study which was published in Intensive Care Medicine in 2011, they were assessing the safety of the non-invasive ventilation in children less than 20 kilo or less in asthma exacerbation, and they found that utilization of BiPAP in acute asthma is safe and may improve the clinical outcome. Mechanical ventilation, if you reach that point, this point of patient with status asthmaticus, I hope you will not reach to this point, but we will just highlight it quickly. It's very difficult actually to deal with those patients who are mechanically ventilated with the status or a lower airway obstruction related to status asthmaticus. However, it's indicated for patients who's having refractory hypoxemia or following cardiorespiratory arrest, or patients with significant respiratory acidosis unresponsive to the pharmacotherapy. It occurs in less than 1% of patients in the PICU. Of those patients who are admitted to PICU, 5 to 12 patients are requiring mechanical ventilation. Half of those are intubated prior to the arrival to the PICU. Probably because of more of awareness about using or more utilization of non-invasive mechanical ventilation. Children who require mechanical ventilation are at risk of pulmonary barotrauma, nosocomial infection, pulmonary edema, circulatory dysfunction, and steroid muscle relaxant associated myopathy and deaths. This is just an X-ray which showed hyperinflation of the on the left side. And you can appreciate after the patient was intubated, you can appreciate the subcutaneous emphysema on this patient. Intubation requires preparation and anticipation. It's always about anticipation of what's going on and the patient deterioration with a frequent serial assessment. Should be performed by most skilled individual available and at that time. Hypotension should be anticipated because many patients have relative hypovolemia. So you should keep the normal saline boluses at bedside. You might have to give it before even intubating the patient. Histamine producing agents such as morphine or atracorium must be avoided. Ketamine is an excellent anesthetic agent for induction, and it's relatively it has a relatively long half-life and also bronchodilating effect with relatively stable hemodynamics effect actually. Cuffed ED tube should be used as a high ventilatory pressure as those patients with status asthmaticus usually require high ventilatory support. Ventilation strategy in those patients, you have to maintain adequate oxygenation, allow permissive hypercapnia with moderate respiratory acidosis, adjust minute ventilation to maintain the pH more than 7.2, minimize dynamic hyperinflation and air trapping by reducing the respiratory rate, and also increase the expiratory time. I know, Dr. Nabil, I have 2 minutes. Thanks for the reminder. A tracheal extubation actually should happen as soon as possible. And there is no ideal mode of ventilation has been identified in asthmatic patients. As long as you are aware about the ventilation strategy on those patients, you can use whatever mode you prefer to work on. However, the asthma management, ventilatory asthma management is very dynamic. As the patient might have mucus plug and then suddenly open. So you have to be very meticulous about it. I always believe whenever you have an asthmatic patient in the ICU, the physician will always be at bedside and just looking at the monitors and looking at the ventilator screen and assessing the flows and the pressure and the tidal volume of such patient. Bronchoscopy for intubated children with status asthmaticus is not recommended as a routine care. Chest physiotherapy are also not recommended as practice. However, it should be considered for patients with atelectasis and clear segmental or lobar atelectasis. Sedation, as we said earlier, ketamine is an excellent choice, usually combined with intermittent and continuous benzos. When you are going to use opioid, fentanyl is preferred because of less histamine release. Vicronium is commonly used as neuromuscular agent in those patients. And then if you have to go further, if all those interventions has failed, which might happen to your patients, you need to consider inhaled anesthesia. I want go further. Just consider extracorporeal oxygenation for those patients in case all of those measurements has failed. At the end of my presentation, I would like to thank the Prof. Nabil for his invitation through the Saudi German Hospital. And I hope that you enjoyed the lecture, and I was able just to shed a light on status asthmaticus, as we might face more cases in the coming few weeks all over around the world. Thank you so much.
Thank you so much, Dr. Fawaz, for your very informative lecture. And we were honored to have you with us in Saudi German Hospital, Riyadh. We wish that we can repeat this frequently to have from your nice experience and information. So I have just some questions here. We will try to take as much as we can, but I hope that we can answer in a short way. The first one, when dealing with asthmatic patient, what is the very first medication to give?
So as we said, first you have to connect the patients to the cardiorespiratory monitor. You start with beta agonist. You give magnesium sulfate, and also you have to give the steroid as soon as possible.
And oxygen, considering oxygen is a medicine.
As a medication, yes.
Yes, okay, thank you. Second question, how to deal with a child with asthma when leaving the house and when wearing a muzzle?
Hopefully they can reach the hospital as soon as possible. One thing that I should highlight, once we have identified patients in PICU that who's having this status asthmaticus, we should make a consultation for our colleagues in pediatric pulmonology and hook the patient up with them for regular follow-up. So usually we discharge patients from the floor in combination with the general pediatrician or pediatric pulmonology with asthma action plan. So the patient or the caregiver will be we should explain to them what they will do during the emergency. My advice to start the Ventolin MDI as soon as possible, while the patient is trying to get the patient as soon as possible to the emergency department.
Okay. Can you give us an idea about racemic epinephrine used in the upper way obstruction?
Sure. Tranexamic epinephrine, if we are talking about the anaphylaxis-related bronchospasm, it's an important, and you have to give it immediately. If you are giving the patient for example, stridor, it will reduce also the upper airway edema, and it has to be given on back-to-back initially, and then according to the response for the patient. If the patient presents with a stridor or upper airway obstruction in the emergency, once you give the racemic epinephrine, you should keep the patient at least to 4 to 6 hours for rebound upper airway obstruction. So you have to observe them in addition to the steroids.
Okay. When you intubate, if you give muscle relaxant, do you think it will work with a bronchial tree is clamped up?
So if you reach the point that you have to intubate the patient, it means that all the medication has failed to open up the airway. So you need a positive pressure that to overcome the airway obstruction. So so I don't think the neuromuscular agent will have an immediate effect on the airway. However, while sedating the patient and putting them in neuromuscular blockage with the also in addition to the steroid, hopefully that will open the airway. In addition to the, it will reduce the asynchrony between the patient and the mechanical ventilation, but it doesn't have direct effect on the smooth muscles in the lung.
Okay. Regarding Picker score, how to calculate inspiratory and expiratory time in a non-ventilated patient?
It's very good question. So you might have to use the pulmonary function test to elaborate more about those things.
Mm-hmm. Has corona pandemic complicated or changed the approach to the asthmatic child?
I haven't, as you most of you aware, more the corona is more. It's I would call it it's an adult disease. Personally, I haven't looked at the if there is any specific publication that are related to corona and status asthmaticus. I don't know, and I'm not aware if there is any new publication talking about this. However, the mainstay of therapy, as was mentioned, is dealing with the airway inflammation, regardless of the trigger. For example, let's say if the patient is having H1N1, would you treat it with the Tamiflu or not, or the influenza? Would you treat it or not? You will treat it with as antiviral therapy, right? As a conjunction, but you need to control the trigger as well. This is my answer.
Any role for epinephrine nebulization?
No.
Okay.
Unless it's related to the status asthmaticus is related to anaphylaxis.
There's a little bit long.
Let me rephrase the answer. So if you have only the epinephrine and you are not the Ventolin is not available, of course I will use the epinephrine and the racemic epinephrine.
Okay. طيب, the place of echocardiography, diagnosis of pulsus paradoxicus, and lung ultrasound in assessment of critical ill patient to anticipate cardiac arrest and follow up the fluid infusion to avoid overload. There is
as mentioned earlier, I would go with the clinical status of the patient rather than getting more echoes or ultrasound. So you will see it in the outline why you have to do the echo, unless the patient is having comorbidities, or you are wondering that it might be the wheeze is not related to the asthma. It's related more of heart failure.
Okay, thank you very much. I hope that it was not too long for all and for you, but I heartily thank you very much for your attendance with us and for your very detailed lecture. I enjoyed it too much actually, and I hope that we will see you soon, inshallah. Thank you very much, Dr. Fawaz.
Thanks, Prof.
We were honored to have you with us.
Thank you.
Thank you.
Thanks a lot, Dr.
With
Fawaz,
this, we
for
will
that interesting
conclude our
talk.
session today.
Yeah, thank you also, Dr. Nabil.
Thanks a lot.
Thank you for everyone. Thank you for joining us for today's webinar. Seeing you, inshallah, next